Hi, my name is Katie, and this is my patient Reid, and today I will be discussing some of the evaluation and pathologies of the cervical spine and head and face. So first I would like to begin with discussing the primary assessment of a cervical spine or head injury. So the first thing you want to do as you're going over to the athlete patient is you are checking their ABCs, the airway, breathing, and circulation. You're checking the airway for any obstruction, the breathing pattern to make sure that it's not ragged, that it's a normal level of breathing, and you're also checking for circulation. So you're checking cap refill. You're also going to check to make sure there are no signs of shock, and you're looking for any gross deformity or severe bleeding that they may have. I'm also going to discuss the secondary assessment. In the secondary assessment, we're conducting a thorough history. And we're also continuously checking for signs of shock, and we are assessing any injuries that are in the extremities and general wound care. So in the history portion of a head and cervical spine injury, you want to make sure you're locating the exact location of pain and what kind of pain they may be experiencing. So is it a sharp pain, is it dull, is it achy, in the location. You're asking if they have any neurological symptoms such as numbness, tingling, or radiating pain down their extremities. And you're asking if the pain is, how severe the pain is from a scale of 1 to 10, 10 being the highest. You're asking about any previous history of concussions or cervical spine injuries, if they are taking any medications, or if they have any symptoms such as nausea, vomiting, dizziness, blurred vision, if they have any confusion, or if they feel disoriented or irritable or groggy. You're asking if they've experienced any snaps, cracks, or pops when the injury occurred. You're also going to ask about their mechanism of injury. So what happened to cause the injury and why we're doing this evaluation. You're asking about a coup or a counter-coup mechanism. Coup mechanism would be if they were standing still and got struck by a moving object, and counter coup mechanism would be if they are moving and then suddenly come to a stop or are struck by something. During this time, you're also asking about any previous history, how many concussions they may have had, and how long that recovery may have been. And then we can move on to doing your observation assessment. So I'm looking at the patient, and I'm looking at the head and face for any sign of confusion, to see if their behavioral responses are normal for them. Are they conscious? Checking to make sure they're conscious. So I'm doing a Glasgow Coma Scale. And my primary assessment. So first thing I'm doing is checking vision. So in vision, the highest grade you can get is a 4. So I'm asking them to open their eyes. They automatically open them, they get a 4. I'm also checking for a verbal response. If they're able to give me a conscious and a level-headed response, that would be given a 5. And 6 would be a motor screening. So if they're able to move freely, if they're able to do the motions I asked them to do, they would receive a 6 for that level. During this time, I'm looking at the eyes. So I'm looking to see that the pupils are equal, and I'm looking to see if they're reactive to light. So I'm looking straight ahead. I'm making sure that they can see me. I'm doing a check for nystagmus, so I'm going to ask him to follow my finger with his eyes and not his head. Can you look at my finger? You should just move your eyes. With nystagmus, I'm just looking to see if the eyes are able to move freely without any sort of rickety motion. Good. So he's able to do that freely. Observation, I'm also looking for any gross deformity. I'm making sure that, again, there's no signs of bleeding or head trauma, head fracture. I'm looking for bruising around the eyes, around the mastoid, and around the ears. I'm looking at the cervical spine to make sure everything is in alignment. So I'm looking ahead, I'm looking at the scapulas, I'm looking at the cervical spine, and I'm making sure that he is equal and that I don't see anything out of alignment. There's no anterior or posterior displacement. So that would be a part of my observation. Looking at the position of the head and neck during my evaluation, does it look like it's off to the side, if it's side bent and rotated? And looking for any, looking at muscle tone and looking to see if there are any the muscle spasm on a unilateral side. So I'm also looking at the ears and the nose, mouth, and eyes to make sure there's no leakage of fluids coming out. If I suspected that there was, I would do a halo test, which is when you take a piece of gauze and you dab the fluid with the gauze and see if you find an iridescent clear ring, which would indicate that there is leakage of cerebrospinal fluid, or which would also indicate an injury to the spinal cord. I'm also going to do a palpation portion. So during this time, I am going to assess the spinous processes to make sure that they're all in alignment. I'm assessing for alignment, and I'm also assessing for pain. I'm going to do the transverse processes as well. Good. So now I'm going to be palpating the back of the skull first. So I'd like to sit up and talk. So I'm palpating the occiput. Good. The superior nuchal lines, the inferior nuchal lines. I'm palpating the occipital bone, the parietal bone, the temporal bone, the mastoid process, and then I'm palpating the frontal bone. I'm going to come around and start palpating the front of the head and face. So again, palpating frontal bone, palpating the sphenoid underneath. I'm palpating the zygomatic bone, the zygomatic arch, the nasal bone. I'm palpating conoid, TMJ, maxilla, and mandible. And I'm also coming down and palpating the throat. Assessing for pain, anything out of alignment or gross deformity, anything that doesn't feel normal on this type of patient. So next I'm going to be palpating the soft tissue structures. So I'm going to start here. Okay, I'm going to palpate the sternocleidomastoid. Good. I'm palpating the scalenes. Good. And then I'm palpating the vater scapula. So after we do our palpations, we can do some range of motion assessments if they are appropriate for that time. So what I would like you to do is bring your chin down to your chest. Good. Come on. I want you to bring your head and neck back towards the ceiling. Good. Sit up nice and straight. Now I want you to bring your left ear to your shoulder. Good. I want you to do the same thing but on your right side. Good. Now what I would like you to do is rotate your head to the left and then back to me. Now rotate your head to the right. Good. Then I'm asking if they had any pain with that, any discomfort, if they had any numbness or tingling with any of those motions. and then I'm going to do it passively. So what I'd like for you to do is lay down with your head on this side. Back. I just want you to rest your head in my hands. Come back just a little bit more. Just relax. I'm going to do the motions for you. You let me know if you have any pain or any neurological symptoms. So I'm bringing him into flexion. Slowly bringing him into some extension. Good. And a side bend to the left. Side bend to the right. And rotate him to the left. And then rotate to the right. You can move forward and pull yourself up. So during that time, I'm checking to see, again, if he has any pain or limitations with any of those motions. And during that time, they would be giving me their feedback based on all of the range of motion that I'm doing. So next I'm going to do a neurovascular assessment. So I'm going to be doing some vital signs. I'm going to be checking the pulse. Pulse should be between 60 to 100 beats per minute. So making sure it's a strong pulse. Good. It's good. It's not weak, it's not rapid. So he's at about 66 beats per minute. During that time, I'm also evaluating his respiratory rate, which normal would be 12 to 20 breaths per minute. I'm also going to do blood pressure assessment. So I would get the blood pressure cuff and I would get the stethoscope, and he should be within the 120/80 range. And I would be also doing capillary rainbow. So when I press down on the thumb, it should be pink. When I press down, it should be white, and then the blood should fill that white space as soon as I let go. During this time, I'm also going to do an upper motor neuron lesion assessment. So I would be doing the Babinski and I would be doing the Oppenheim. So what I would like for you to do is take off both shoes and socks. Good. I want you to put your head on this end and your feet on this end. Slide towards me just a little bit. And I just want you to lay back and relax. The first one I'm going to do is Babinski. So without him knowing, I'm going to choose a side to go first. I'm going to do the sharp end. So a normal sign would be the toes curling. A positive sign of an upper motor neuron lesion would be if the toes were to splay and the great toe were to extend. Also going to do the Oppenheim assessment. This is where I'm taking a sharp edge and I'm scraping it up the length of the tibia. This would be excruciatingly painful for someone who doesn't have an upper motor neuron lesion. And again, a positive sign of a person having this would be great toe extension and splaying of the toes. So I'm just going to lightly go up. Normally you would do a normal pressure. And those would be the tests you would do for an upper motor neuron lesion. Next, I'm going to do the dermatomes and myotones of the upper and lower extremity. So I'm going to start with the upper extremity. So first I'm going to do is C4, which is the top of the shoulders. I'm going to move down into C5. And then I'm going into C6. C7, C8, and then T1. Those are the dermatomes for the upper extremity. I'm also going to do myotomes. So what I'd like for you to do is bring your arms up to your side, hold them there. This is C5. C6, hold that. Down. C7, hold it right there. C8, hold your thumb right there. Good. I want you to squeeze my fingers. And then that is T1. Keep them splayed out. Good. Now I want you to curl your fingers. Good. And that would be the myotomes of the upper extremity. I'm going to now do the dermatomes of the lower extremity. L1, L2, and L3 are out here. L5 and S1 down here. And then L4 would be out here. I'm also going to do the lower extremity myotomes. So what I'd like for you to do is bring your knee up towards the ceiling. Hold it right there. This is L2. Good. I want you to kick your leg out and hold it there. This is L3. Good. Next I'm going to do L4. So bring your foot up towards the ceiling. Hold it right there. L4. Good. Relax. Now I'm going to do great toe extension. Bring the toe up. Hold it there. Good. That's L5. S1 is ankle eversion. So kick your foot out. Good. Hold it right there. Good. Now I want you to do is hop off the table for another one for S1. Raise your toes. So stand on your tiptoes. 5 seconds. S2, I'm going for you to lay on your stomach. Bring this foot up. And I'm doing knee flexion. Hold that right there. Good. Relax. Now I'm going to do a cranial nerve assessment. So I'd like for you to sit on the edge of the table. So first, I'd like for you to sit nice and tall. So I want you to close your eyes. I want you to tell me if you can smell the rubber.
Mm-hmm.
Like you open your eyes. Could you tell the time for me, please?
8:30.
Next, I'd like for you to follow my finger with your eyes and not your head. Now I want you to clench your teeth for me. Clench like this. Good. Can you smile? Aww. Now I want you to close your eyes. I want you to just tell me, say yes if you can feel me touching you, okay?
Mm-hmm. Yep. Mm-hmm.
Okay. Keep your eyes closed. I want you to tell me which side you can hear the noise on, okay?
Right. Right. Left. Left. Left.
Good. Now what I'd like for you to do is stand up. I want you to balance on one foot for me. Choose which one. Hold it there for 5 seconds. Relax. I'd like for you to balance on the other foot for 5 seconds. And relax. You can see. Can you swallow for me? Good. Can you stick out your tongue? All the way as far as you can.
It's as far as I got.
All right, can you do it again for me? Say ah.
Ah.
Good. Can you raise your shoulders for me? Nice. Keep them right there. Relax. And those would be the cranial nerve assessments that I would do. You can also do some functional assessments that can also indicate concussion or a cranial nerve issue, injury. So the first one I'm going to do is the Romberg test. So could you please stand up for me, please? Take another step out. Another step. I'm going to stand behind you. So what I would like for you to do is put your hands on your hips. I want you to raise your left foot off the floor. Balance just like that. I want you to close your eyes and tilt your head back as far as you can.
Yeah, that's not happening.
Clinician is standing behind just in case they get unstable. If they were able to do this test, you would ask for them to take one hand off and touch their nose and bring it back. So in this case, it would help to know what their Romberg test would be before, as like a baseline to see what they're capable of before performing this test, because as you can see, for some people, it's just not feasible for them to do even when healthy. So next we're going to do is a tandem walk. So what I would like for us to do is come back here towards the door. And what I would like for you to do is walk heel to toe towards that table. So you're going to walk heel to toe, hands on your hips. You're going to walk to the table, and then you're going to walk back heel to toe, just like this, to the starting position. So could you do that for me? I'm going to clear a pathway for you. During this time, you're checking to make sure that they are stable, that they're not wobbling, that they're able to walk heel to toe without falling. You're standing behind them to make sure that they're not about to fall over and cause more injury. All the way to the table for me. Good. Go ahead and go backwards. Good. Great. So those would be 3 of the functional assessments that you can do if you suspect a head injury. I'm also going to talk about some of the pathologies that should be included in your differential diagnosis of a cervical spine or head injury. I'd like to talk about concussion first. So if you suspect a concussion, it's gold standard to do a SCAT, and you would have a baseline of their concussion score, and then you would have that baseline to compare to their SCAT-3 score during the time of the injury. You're also going to be asking them some anterograde and retrograde concussion questions. So the retrograde questions would be questions they'd be able to answer that happened before their initial injury. So you could ask questions like, what is your name? Where are we? What is the score of the game? Do you know who you're playing? Questions like that. And then you could ask the anterograde questions, which would be things that they would have to remember after the initial injury. So you would give them a list of words that they would have to repeat back to you, and then you would ask them to repeat those same words 5 minutes or so later. You could also ask them to repeat a list of numbers backwards from how you have said them to them, which would be another way of testing their analytical skills. We can also do a test we can also check to see if they have a skull fracture. So for skull fractures, you're looking for a battle sign that would occur behind the ear along the mastoid process, any bruising back there. You're also looking for bruising underneath the eyes, which would be called raccoon eyes, another indication of a skull fracture. And then spinal cord injury, again, a positive halo sign, which I discussed earlier, would indicate a injury to the spinal cord. Positive sign would be the iridescent clear ring, which is cerebral spinal fluid. We could also, another pathology would be a cervical spine dislocation or fracture. So when you're doing your palpation of the cervical spine, you're feeling for any crepitus. You're also, which it could indicate a fracture. You're also looking for any displacement indicative of a dislocation. Another key sign of dislocation would be if when you found them, their head was laterally flexed and rotated with muscle spasm on the unilateral side. We're also looking for signs and symptoms of an intracranial hematoma. There are two key types. There's the epidermal hematoma, which is atrial bleeding that occurs in the brain, and the onset of symptoms would be right away. It would be rapid onset. They would have an increase in their symptoms hours after the initial trauma. So when you're discussing concussion symptoms to the patient, you're telling them that if they have an increase in their symptoms, increased headache, vomiting, dizziness, consciousness, they need to seek medical attention immediately. Another type of intracranial bleeding would be a subdural hematoma, which is very dangerous. That would be venous bleeding, and that occurs, the pressure with the venous bleeding is much slower, which means the onset could be slower and could occur, their increased symptoms could take as long as days or weeks. So it's important that they know if their symptoms are gradually getting worse, that could be a sign of that type of hematoma. And it's important for you as the clinician to keep checking their symptoms to make sure they're not getting worse. And if you suspect that they are getting worse because of this injury, you need to refer them immediately and get them medical attention. So those are just a few of the pathologies of head and cervical spine injuries. And that is the conclusion of our video.